Live. Guys, we are live. We're live. Okay. So good afternoon and welcome to Health and Government Operations Committee. We have hearings now. Your Chairman, Jocelyn Peña-Melnick, joined by my Vice Chair, Bonnie Callison. I'm going to go through some very fast rules, please. If we encounter any technical streaming issues, please bear with us. We will take care of it. Put your electronic devices to vibrate. There's no food or drinking in the gallery. Here, we're going to have the sponsor and witnesses. The sponsor in this committee is not limited. However, please, no more than 5 minutes. Witnesses have 2 minutes to provide the testimony. When the timer goes off, please wrap it up. For the committee, please adhere to one question and no story, just a question. Keep it brief. Members of the public will be able to view the live stream of this hearing on the Maryland General Assembly website and YouTube. Today, we will hear the bills in the following order: 1187, 1314, 1291, 1310, and we will conclude with 1086. House Bill 1187, is a delegate here? I do not see her. Let's do House Bill 1314. Delegate Miller? All right. Delegate Bandari, can you do us the favor and let's do yours? See, we're nice here. We do us later and take the delegates that are not on this committee first. But since they're not here, we're going to go with Bandari. Prescription drug repository, what is it? Repository program out of state pharmacies. Thank you so much. Do you have a panel? Do you want to bring them?
Yeah, you want to come?
You have Deborah Brocado. No, you have George Wayne is virtual.
Yeah.
Can you bring the virtual witness, please? Thank you. All right. Delegate Mandari, you can get started.
Yeah. Madam Chair, Madam Vice Chair, and distinguished member of wonderful committee. House Bill 1310 expands the Maryland Prescription Drug Repository Program to allow participation of out-of-state pharmacies, thus increasing our state access to affordable, donated prescription medication. A July 2022 survey of over 1,300 Maryland adults revealed that 55% experienced at least one healthcare affordability burden, while 48% encounter at least one cost-related barrier to healthcare within the prior 12 months. Specific to medication, 23% of our state respondents reported either cutting pills in half, skipping medication doses, or not filing prescription due to cost. While broader national and state policies, including in our state, have begun to address the prohibitive cost of prescription drugs, there is an urgent need for immediate action to increase access to affordable prescription drugs. Prescription drug donation has significant potential to increase medication access. Up to 11 billion in unopened, unexpired drugs are destroyed each year, including 5 billion thrown out by either hospital or long-term care facilities across the United States. These drugs can often be safely collected and redistributed to other patients in need at a very low cost. Redistributing these drugs will increase access to affordable drugs for Maryland patients and reduce medical waste. The key issues in doing this work at a scale is the ability to match patients in need to the drug that are available. In 2006, the Maryland Senate and House of Delegates both voted unanimously to establish the Prescription Drug Repository Program. This legislation provided for a network to safely dispense donated medication to needy patients. However, the current structure of the program is not meeting the original goals. Currently, there are only 2 independent pharmacies in our state approved by the board to redispense donated drugs. Although many pharmacies would like to participate in the program, there are a number of barriers that have limited participation, especially limiting the ability of out-of-state pharmacies to participate. This bill allows the board to approve an out-of-state pharmacy as a repository, which would allow our state resident to participate in efficient drug donation arrangement between multiple states and allow our state donors and patients to work with the best organizations in the country that specialize in collecting and redistributing donated drug. Thank you in advance for joining in this effort to provide access to affordable drugs for our residents, and I urge favorable report on this very important bill.
Thank you. And your panel, the panelist is here now, George Wang. Let's bring him up, and then we'll open it up for questions, delegate.
Sure.
Mr. George Wang, will you be so kind and start your testimony? How are you today?
Hello, yeah, I'm great. Can you all hear me?
Yes, we can.
Great. Well, thank you so much for giving me the opportunity, Madam Chair, and members of the committee, to speak to you today. I am George Wang, one of the co-founders of Serum. We are a nonprofit founded about 14 years ago. We operate drug repository programs today in 11 states and are the national leader in this space with the largest redistribution network of surplus medicine in the country. To date, we have helped get 2.5 million prescriptions worth nearly $300 million to help patients in need. We have also provided expert advice on over 25 bills and regulations around the country. We've seen programs in other states greatly benefit from allowing out-of-state entities to participate in their in-state programs. One example of this is in Georgia. We helped launch Good Pill Pharmacy in 2017 as part of the Georgia Repository Program after a similar legislative effort. Good Pill Pharmacy has also licensed as an out-of-state participant in Illinois' Repository Program. Good Pill partners with free clinics all over Georgia and Illinois, helping patients get access to medicine they need to stay healthy, delivered directly to them. Good Pill is poised to participate in Maryland's program with the proposed amendments. Good Pill today is saving patients on average of $150 per month and has filled over 981,000 prescriptions worth $78 million. Good Pill's formulary includes most of the top 300 drugs dispensed in the U.S. that treat diseases like hypertension, diabetes, depression, among others. Good Pill offers affordable, transparent pricing with an admin fee of about $6 per 90-day supply for most meds. We support HB 1310 with amendments, and we ask you to do the same. We believe that allowing out-of-state entities to participate, Maryland can become a national leader in drug repositories, benefiting low-income Marylanders who struggle to afford their medication and preventing environmental impact of pharmaceutical waste. Thank you for the opportunity to submit this testimony.
Thank you for being here with us. I'm going to open it up for questions. I note that Andy's here from the Prescription Drug Affordability Board as well. Delegate Johnson.
Thank you, Madam Chair. Thank you, Delegate. If you could explain to me just a little bit about the out-of-state repository, how that would work. Is that out-of-state drugs coming into Maryland, or Maryland drugs going out-of-state for other folks in those states? Exactly how is that going to work?
Mr. Wong, did you want to provide an answer, or do you want me to?
I can chime in here. So it would be that Marylanders would be able to receive medicine that is from an out-of-state mail order pharmacy. So this out-of-state mail order pharmacy, there's one of a few of them around the country. They take in donated medicine from places around the country following those regulations, and then they will be dispensing those to Marylanders at low cost or for free. In addition, it may allow folks in Maryland to have surplus medication to donate to the program, whether it's in-state or sometimes if there's need for it out-of-state and there's no need in the state of Maryland, it might go out-of-state too. But really, it's about breaking down these barriers so that these programs that are run by nonprofits can be efficient and can help patients, whether they're in Maryland or in other states.
Follow up, Madam Chair?
Yes.
So when Marylanders donate drugs, do those drugs get prioritized with Maryland repositories first?
That's
So
right.
just-
Yep, that's the intention. So Maryland surplus would be going back to Marylanders. That being said, the reality is there are actually more states that are donating to the small number of states that have repository programs that work. So Maryland would be among that bunch. Essentially, there are other states' medicines that are being donated that don't have anywhere to go. They get checked to make sure they're safe, everything is good, unexpired, unopened, all those things. And they would be going to help people in states that have these repository programs set up.
All right, thank you. Thank you, Madam Chair.
Welcome. Thank you for the question. Any other question, Vice Chair Collison?
Thank you, Madam Chair. And thank you, Delegate Bandari, for this bill. So I actually was surprised to hear that we had a repository here in Maryland. I have, on a number of times, tried to return medicines that are unopened and unused, and never found anyone who would take them. And I'm talking about pharmacies. So, and you have, so I guess, and maybe, Dr. York, you have an idea about how that program is currently working. But also, the Board of Pharmacy is saying that it needs staff. Do we, in order to monitor out-of-state licenses, do you have any insight into that?
Yes, thank you, Vice Chair. So I can just, we provided some of the technical background on this, just understanding kind of the issues in this space. And I think, so we looked into this program. I'd say, I forget when the original law was passed, but it passed with good intention. The general idea is we have a very large number of drugs that are just thrown away that could otherwise be used by patients that could use them. So there's two, I think, small independent pharmacies that are currently in the state that are doing this program. And so I would say the program is a success. I think the issue is the scale. And the biggest issue is, drugs come in as they're available, and then you have to match them with patients. So I think the problem that is solved with this legislation is you have an organization such as Serum that works at a large enough scale that you have enough drugs coming in that you can find enough patients that match with them. So I would say it's successfully working in Maryland, especially with our independent pharmacies, which are always kind of at the cutting edge of these things, but it's at such a small level that the actual number of patients served is probably not as many as you would have hoped for when you passed the original bill. Oh, and then you asked about staffing. We defer to the Board of Pharmacy. There is an element of managing out-of-state pharmacies, so I think this would be registered as an out-of-state pharmacy, and I defer to them on if there's an additional burden on that. We don't expect, the same way that we see one or two in, repository programs in Maryland, we would probably expect a handful outside of the state, so we don't expect like this boom of out-of-state repositories to come into the program.
And if I may, Madam Chair, so this particular program, though, is national, and the drugs that they're receiving could be, if there's not a need in Maryland, and as I heard Dr. Wing say, the Maryland's drugs come back to Maryland to the extent feasible, but if there's no need, there might be a need in Delaware, West Virginia, wherever, for drugs that a Marylander is no longer using or has not used. It's not because it's unopened and unused.
Mr. Wong, did you want me to answer that? Or I think the short answer is yes, that's correct.
Yeah, that's the intention. Yep.
Yeah.
Okay.
But there's more donors from across the country coming in, so it's going to be a net positive to Maryland patients.
To Marylanders.
Yeah.
Got it. Okay. Thank you very much. Thank you, Madam Chair.
Delegate Hill.
Yes, so Dr. Wang, I just wanted to be clear, what happens, how does this not, as the numbers go up and down, how do we ensure that these two small Maryland repositories don't get run out of business?
I can take an answer
Okay.
on that. So the repositories, it's like a side item of business. And Vice Chair Collison also mentioned the disposal. That's almost like a separate program. Like if you have to dispose of your drugs, there's a number of pharmacies to take those. There's only two that can redistribute unused, safely donated drugs. And it's a sideline of business. So they're generally independent pharmacies. They don't make any money off the repository program. It's like a public service that they provide. So I don't think there's any risk of them losing any line of business or anything
So
like
that it's not that the patients that they would normally give to are now getting from this out-of-state thing and they have nowhere to take their donations. because they may not be able to send their donations out of state, so they'll not have to destroy them, right?
That's correct. So any that go to the 2 Maryland repositories, I understand that those medications will stay in Maryland, but the volume is just so low because it's such a small, again, the scaling is the issue. So it's a service that they provide to their patients. It's not a line of business. They're not making any profit off of it. It's a public service that they're providing to take medicines and then try to do the greater good of giving those drugs away rather than throwing them away. Yeah.
Delegate Johnson.
Thank you, Madam Chair, for the second bite. So how do the Maryland patients, how do you link the Maryland patients and the repositories? How do they know is there a sign up, or how do they know that this exists and that they can get cheaper drugs? And how do out-of-state repositories link to Maryland patients?
Mr. Wong, did you want to answer or do you want me to?
Whoever's best to answer the question.
Okay, I can take a pass, yeah. So basically the way that this will work is Maryland, so the donations generally come from businesses, so like centralized places. So you can picture like hospitals or nursing homes that have just this huge bunch of drugs that they would otherwise just have to throw away. Instead of throwing them away, they send them to a repository. This repository, I believe, is located in Georgia. And then they aggregate that entire pile of drugs. And then any Maryland patient that needs drugs and is a qualifying patient goes onto their website and they can see the stock of drugs. And then they click on it and say, I would like these drugs. And then they get mailed ordered. Almost it's just like a normal pharmacy. You get a prescription and it's mail ordered to you basically at nominal shipping costs. So it's basically I think it's a non-profit model. I don't want to speak too far about that, but I'm not sure if that answered the question.
Well, part of it. The other part was, how do Maryland patients know about this repository and know that they can get these drugs?
So that's up to Maryland to figure out, and that's part of the reason that I think we were pulled into this discussion, is just because it is probably going to be an advertising campaign. There are probably some rollouts from different state resources. We're working on a rollout to make this available to patients, and then also the Maryland Prescription Drug Affordability Board, again, probably another reason why we're participating in this on a technical level, is we have a navigator program. So when patients come to us and say, I can't afford your drugs, we walk them through the resources that are available. This would now be one of the resources that we would point patients to.
All right, thank you. Thank you, Madam Chair.
If I may, I'll just say that,
Excuse me, so we already got the answer and he's satisfied, so we have to keep moving because we have a hard stop at 4 o'clock today, and we have still many bills on the agenda, okay? And this bill will go to subcommittee, so, you get to discuss it more there as well, okay? Any other questions? I do want to bring up the fiscal note. That little pesky fiscal note is over $112,000. I know I just asked Vice Chair Collison, Delegate Bandari to work with you to contact the Board of Pharmacy to bring that down, because we cannot pass it if it's more than 75 grand, okay?
Great, thank you.
All right. Thank you so much. We have one more. Thank you for being with us. We really appreciate you. And we have now an unfavorable panel. Deborah Brocado, is she here? Okay, will you be so kind and come up? Good afternoon.
Good afternoon. Deborah Brocado with Maryland Right to Life. On behalf of our Board of Directors and followers across the state, we oppose House Bill 1310 without an amendment to exclude its use for abortion purposes. Maryland Right to Life opposes the promotion and funding of abortion, including the expansion of accessibility to the dangerous and deadly abortion drugs. This bill extends the prescription drug repository program to pharmacies outside of Maryland. The state of Maryland already spends over $33 million for abortion including the use of taxpayer-funded Medicaid to cover the cost of abortion drugs. Governor Westmore and the Board of Public Works spent over $1.3 million taxpayer dollars to stockpile the 2 abortion drugs. So now this bill would have Maryland taxpayers paying for drugs going to other states. Marylanders have many other health concerns such as diabetes, wound care, heart disease, lung disease, post-operative care, et cetera, and the list goes on, that should be addressed, but the state of Maryland prioritizes abortion. Abortion is not health care and is never medically necessary. Abortion enables the exploitation of women and girls by sexual abusers and sex traffickers to continue their crimes and victimization. This increased accessibility to abortion drugs means that abusers and sex traffickers will also have increased access. Marylanders do not want to participate in abuse and coerced abortion of women and girls. To prevent appropriations from this bill from being exploited by the profit-minded multi-billion-dollar abortion industry, we ask for an amendment to exclude abortion purposes from this bill. Without the amendment, we urge an unfavorable report. Thank you.
Thank you for your testimony. Are there any questions for this witness? Seeing none, thank you very much. This concludes the bill hearing on House Bill 1310. Let's move on again to House Bill 1187. Health insurance scalp cooling systems require coverage. Good afternoon, Delegate. Will you be so kind and bring your panel? I have Amy Tanner, Elizabeth Lord, Kendra Sherflift, Elizabeth Schulk, and Rosalind, and that's it. Then there's a virtual one, Mark Goldstein. So if you could bring chairs up, please, and come up. And Delegate, you can get started.
All right. Thank you, Madam Chair,
You're welcome.
Madam Vice Chair, committee members. For the record, my name is Delegate Latoya Congola, representing District 1, and I come to you to request a favorable report for House Bill 1187, Health Insurance Scalp Cooling Systems Required Coverage. But before I tell you about the bill, I want you to really lead with empathy. And I just want to ask you all, how would you feel if you had to shave your head today and come into work tomorrow? While that can be a choice for you, it's not a choice for those undergoing chemotherapy. And think about that this can be any of us, this can be your family members. So this bill has received bipartisan support because we recognize that cancer and chemotherapy-induced hair loss does not discriminate. Scalp cooling treatment is relatively unknown to the general public, but this is a groundbreaking medical advancement that has been proven to significantly reduce one of the most visible and emotionally distressing side effects of chemotherapy, hair loss. Today, I urge you to support legislation that will expand access to this critical treatment, ensuring that all patients, regardless of their financial means, have the opportunity to preserve their dignity, confidence, and sense of self during one of the most challenging times of their lives. Chemotherapy is a life-saving treatment, but it comes at a significant cost, not just financially, but emotionally and physically. For many patients, hair loss is not just a cosmetic issue. It is a visible marker of illness that can impact mental health, self-esteem, and even employment opportunities. Studies have shown that scalp cooling systems, which work by reducing blood flow to hair follicles during chemotherapy, can significantly decrease hair loss, helping patients maintain a sense of normalcy and control. Despite its proven effectiveness, scalp cooling treatment remains out of reach for too many patients due to high costs and lack of insurance coverage. This is unacceptable. No patient should have to forego an effective treatment simply because they cannot afford it. We must act now to ensure that private insurance providers recognize scalp cooling as a medically necessary option and provide coverage accordingly. Supporting legislation for scalp cooling treatment is not just a matter of health care, it is a matter of compassion and empowerment. By passing this legislation, we will only ease the emotional burden of cancer treatment, but also reaffirm our commitment to patient-centered care. New York State recently passed a similar bill, and my goal is for Maryland to lead the way as the next state to follow suit. I have uploaded an amendment in the floor system, and it has been emailed to all committee members. I thank you all for your consideration, and I respectfully request a favorable report for HB 1187. Thank you. Okay. And next, I would like to have Amy, and then we'll have Dr. Goldstein, who is virtual, and then we'll work our way down the table.
Okay, so I don't always look like Dolly Parton. This is reality. My name is Amy Tanner. I'm speaking about HB 1187. I'm an outspoken mother of 3 young adults and 1 tolerable teenager. I was diagnosed with a very aggressive form of breast cancer. Sorry.
Your story, you could just take your time, okay? There's no rush.
Amy's a wonderful member of our community, and she advocates very strongly for kids and does a great job, and we really appreciate her.
Triple negative is 10 to 15% of all breast cancer cases and a 1 in 5 diagnosis for all African American women with breast cancer. It requires chemotherapy and fast. Chemotherapy robs women of their dignity. The lengthy list of symptoms that we endure is not for the faint of heart. One symptom that we can attempt to help with is the loss of our hair. Our hair is part of our identity, femininity, and as I found out the hard way, it keeps us warm in the winter. Cold capping gives women a chance to keep their hair and still feel like themselves. My cold capping was not going to be covered by insurance, and the cost was $2,500. If given the choice of having it applied to my deductible and out-of-pocket insurance costs, I would have done it. It would have been financially feasible. I will likely reach the $8,000 out of pocket anyway. Please do for Maryland women what New York was able to accomplish. Please give them the choice to help them continue to feel normal while they are going through hell. Thank you.
Thank you. I just want to say on behalf of the committee, thank you for being here. Thank you for sharing your story. And, you know, our prayers are with you, okay, for full recovery.
And I'm going to win, so it's
You are.
okay.
We're gonna claim it for you.
That's right.
Okay, it's done. Next, please.
Okay, Dr. Goldstein?
Good afternoon. Can you hear me okay?
Yes, we can.
Okay. Good afternoon, delegates, colleagues, if you're out there, guests, and other members. Thanks for having me here today. My name is Dr. Mark Goldstein. I'm board certified in internal medicine, hematology, and oncology. I've been practicing in Maryland since 2008, straight out of fellowship. I'm here to testify in support of HB 1187, which intends to secure insurance coverage for scalp cooling, a technique used to prevent hair loss caused by chemotherapy. As many of you are aware, cancer is common. In 2018, for example, there were over 32,000 cases of cancer in Maryland alone. Not all patients require chemotherapy, and not all chemotherapy agents cause hair loss, but many do. I've seen firsthand the emotional and psychological toll it takes on patients who are already in distress from the cancer diagnosis and its implications. I've also seen this in my cousin, who was diagnosed with breast cancer around age 40, and my 20-year-old daughter, Lily, who was diagnosed with cancer in November 2024 and just received her last chemotherapy on February 24th. Currently, insurance provides some coverage. Some insurances provide some coverage for cold cap, very few, but most insurance companies provide coverage for a wig, which we are required to call a hair prosthesis on a prescription. For many patients, this is uncomfortable and often does not provide the look they want and may even draw more unwanted attention. In December 2024, as you heard, New York became the first state to pass a law requiring insurance coverage for scalp cooling. As the president of the Maryland, D.C. Society of Clinical Oncology, and now as a caregiver, excuse me, I'm here to advocate for patients across the state of Maryland who may benefit from scalp cooling to try to preserve their hair and perhaps their dignity without having to spend thousands of unreimbursed dollars to do so. I humbly request your vote in favor of this bill. Together, we will make Maryland the second state in the country to require insurance coverage for this important intervention. Thank you for your time and attention, and please let me know if I can address any questions you may have.
Being here, I know how busy you are. And also, thank you for sharing your story about your daughter, and I send you prayers for a quick recovery as well for her. Thank you. Who's next? And if you could be so kind and just put the microphone closer to you, whoever speaks, so that we can hear you well.
Thank you for having me today. It may not look like I have flowing locks to a lot of people, but I fought for every hair on my head. Almost exactly 1 year ago, I was diagnosed with stage 3 invasive breast cancer. 4 surgeries, 16 chemos, 25 sessions of radiation later. The hardest 2 weeks of this entire journey was when I went through what we in the community call the big shed. The big shed started about 3 weeks into chemo, and during this time, my hair came out in fistfuls all day long. I was afraid to take showers because although I knew logically the shower wasn't making my hair come out, every time I shampooed, my hands would be covered in giant clumps of blonde hair. I was devastated. For the first time, I felt like the helpless cancer victim I had seen in the movies, but had never imagined for myself. And I was angry. I was angry at my ecologists for doing this to me. I was angry at the universe for making me get cancer in my 30s. And silently, I screamed at everyone who told me, it's just hair, it'll grow back. But after 2 weeks and about 80% of my hair, the shedding stopped. Because as hard as this was, I was actually lucky. I was cold capping. I cold capped through all 21 weeks of chemo, and as a result, never lost all of my hair. In the beginning, I was on one of the harshest regimens. We actually call it the Red Devil, and this is when I had the big shed. But about halfway through, I switched to a much more tolerable drug, and my hair actually started growing back. I'm in a cold capping support group, and many women who only had this more tolerable drug report they didn't lose any hair while cold capping. By the time I rang the bell on January 2nd of just this year, I had no bald spots and enough hair to stop wearing hats and wigs. For me, cold capping and keeping what hair I could meant that in the middle of chemo, I could confidently attend a Taylor Swift tribute band with my nieces, and when chemo was over, I could actually stop thinking about it because I didn't have a daily reminder on my head. I would never have had the gift of dignity and competence if friends and family hadn't stepped up. Cold capping was not covered by my insurance and cost me $2,400. There was no way I could bear this cost alone. I don't think the access to something that was so important to helping me through the hardest thing I have ever done should be only for those who can afford such a huge cost. Dignity should not financially ruin you. Thank you.
And thank you for sharing your story, and I'm so glad you're here. Next, please.
Thank you for having me. I'm Liz Lord. I'm also a breast cancer survivor. I was diagnosed at age 42 in 2016, and I prevented hair loss using cold caps. I just wanted to talk about what Amy's going through for a minute, which is imagine when your insurance company will cover the cost of mitigating every side effect except the one that is the worst. They'll pay for Zofran, which is anti-nausea. They'll pay for steroids to reduce swelling, but they won't pay for you to prevent hair loss. There's an NIH study that says that 56% of patients report that that is the worst side effect, and yet it's not covered. I'm here because I founded a nonprofit organization called Cold Capital Fund. On the heels of my own experience, I had access and I could afford cold caps, but I looked around my infusion center and realized that others couldn't. Since 2018, we've paid out $165,000 in financial assistance, I believe to you as well. And we've supported over 200 patients. We've received 650 applications in that time. The demand is overwhelming. There's only so much that I and my board members can do from our kitchen tables to support this immense need from DC, Maryland, and Virginia. As others have said, this is about normalcy, dignity, privacy. The stories I hear from patients are, I'm a 25-year-old who just started working on Capitol Hill. I don't want people to know I have cancer. I'm a 50-year-old grandmother. I don't want my grandkids to be afraid. I'm going to die from breast cancer. This is my second round. I don't want to die not looking like myself. So we have filled a gap that should have never been there. There's only so much we can do. Frankly, we are going to have to shut down this year after nearly 8 years of very, very concentrated fundraising, tapped into foundations and networks. But ultimately, this is a gap that shouldn't be filled by breast cancer patients and nonprofit organizations like Cold Capital Fund. This should be covered by insurance companies, much like they cover every other side effect related to chemotherapy. So I appreciate the opportunity. I've wanted to see this happen for 7 years. And I think it's high time that Maryland adopt this, much like they've done in New York. So thank you.
And thank you for sharing your story as well and for being with us, okay? Next.
Hi, my name is Kendra Shurtleff, and I'm a resident of Anne Arundel County. I was diagnosed with hormone-positive breast cancer on March 17th, 2022. Happy St. Patrick's Day, right? 2022 was the year my oldest graduated from high school and my youngest was graduating from middle school. I was at that sweet spot of parenting where I had a little more freedom, I could rekindle some friendships, get some new hobbies, and it was my year of yes. I was looking forward to adventure, looking forward to new things to come. Breast cancer, surgeries, radiation, chemo, and losing my hair was not what I was looking forward to saying yes to. Like, let's be real. But I embraced the fight. I figured it was going to teach me something, and from the beginning, I was determined to be a breast cancer thriver, not just a survivor. I've worked in oncology for over 20 years, and there were many lessons to learn. It taught me to be agile. Treatments are just a treatment plan. They move. It taught me to make decisions very quickly based on the information at hand. It is information overload, and decision fatigue is real. Do you want a lumpectomy, mastectomy? What type of reconstruction? We're going to have chemo. No, we're not. Yes, we are. We're going to do surgery first, chemo first. It is everything coming at you. And it taught me to navigate the financial burden of a cancer diagnosis. We've hit our out-of-pocket max every year since my diagnosis. This year it's $13,000, and we're more than halfway there with all of my follow-ups. According to Bankrate in 2023, the emergency savings report, more than half, 57% of Americans cannot cover an unexpected $1,000 expense. I'm here to tell you, nothing is more unexpected than a cancer diagnosis. And according to the American Cancer Society, nearly half of cancer patients and survivors have medical debt related to their cancer. And of those, 49% carry over $5,000 in medical debt. The interesting part to this is nearly all, 98% of those patients had insurance when the debt was incurred, and the health implications are significant. Folks with medical debt are 3 times more likely to be behind on breast cancer screenings. 27% with cancer-related medical debt have gone without adequate food, and 25% have skipped or delayed care. The impacts of cancer-related medical debt are not felt equally, and there is healthcare disparities. Black and Hispanic patients and survivors with medical debt are twice as likely as white respondents to report being denied care due to their debt. Black respondents also are more likely to report being contacted by collection agencies. The out-of-pocket costs are real, and they are debilitating. As soon as I discovered I would need chemo, I asked about cold capping. Again, I've worked in oncology. I had the benefit of knowing about it. The first words out of my nurse's mouth were, before you decide, you should know this is not covered by your insurance. She wasn't saying it out of malice. She was saying it because she knows about the financial toxicity associated with a cancer diagnosis and what it brings to families. I was lucky. I only had 4 cycles of chemo, and I paid $1,200 out of pocket for my cold capping. She was right. $0 were covered. Keeping my hair is important, but just so we're clear, it has nothing to do with vanity. It is about preserving dignity. It's about being able to go to work and not having people say, what's wrong with Kendra? What's going on? It's about being able to the grocery store. When you're in the bathroom in the morning brushing your teeth and you look up, there's you in the mirror. It's not someone you don't recognize. It was also about preserving the look for my daughters who were scared they were going to lose their mother, for my husband to look over to his wife of over 20 years to recognize that I am still who I am. It's all about preserving your dignity and having the choice. Bald is beautiful. It really is. It was not me. I have a really funky shaped head. I learned during the treatment. But that's my story. I was lucky enough we could afford the $1,200 payment. What about the folks who can't? I belong to a group called Immerman's Angels, and what they do is they match cancer patients of all different diagnoses with new patients, almost as a mentor-mentee relationship. My most recent mentee can't afford it. She's a teacher. She's shaping our youngest minds in our communities. She is a grandmother and a mother, and she deserves to have dignity. I really encourage you to push 1158 into the next committee. Thank you.
Thank you, and thank you for sharing your story, and I'm so glad you're doing well and that you're here.
Thank you.
We really appreciate it, each and every one of you, okay? I want you to leave here knowing that we have a lot of respect and appreciate your testimony. I'm going to open it up for questions now. Actually, no, Elizabeth Schultz, no, she testified already. Yes, it's okay. No worries. I love my committee. They're very helpful. All right, so let's open it up. I'm going to start with Delegate Chisholm, followed by Woods, followed by Hill.
Thank you, Madam Chair. I was looking at the letters of support and opposition. It was 23-1. The one is going to have to come up here. He's a really nice guy. He's got a hard job to oppose this, I promise you. But he does. I was reading the letter, and this would be a mandate, which means there would need to be a premium assessment to it, and that would obviously have to go through the HSCRC. Have you had any conversations with them to see what kind of impact this would have, so that we could have a better understanding of could we get it through? Because this is an incredibly important subject and bill, but we need to make sure that when we do it, we know what the result's going to be, both on the physical, on the budget.
Absolutely.
And so I don't know. Have you had any conversations with anybody at the HSCRC or?
Before you answer, please. Delegate Chisholm, if I may.
Sure.
I'm going to, just for the benefit of our new delegate, every bill that has a mandate, because it's going to affect the premiums, it may or it may not, goes through the Maryland Healthcare Commission. I would say most of them, the Maryland Healthcare Commission, so that they can see how many people it will affect. Is it going to go up by 5 cents or 17 cents, right? And that so that we can decide intelligently whether it can be afforded. Delegate, go ahead.
Okay, and thank you for the question. So I was made aware of the MHCC, and I know we have not had conversations with them about this. However, we did do a cost analysis on some of the other costs associated with providing some sort of what I looked up. It's called cranial prosthesis, or what we know as a wig. And those wigs can go be upwards of $2,000 to $5,000. Whereas if you do the cold capping full treatment, that's even less than a wig. That's anywhere from $1,500 to $3,000. So we're spending more money on wigs where women actually prefer to preserve their own hair. Not to mention the emotional distress, the treatment for depression, anxiety, trauma even. So we're putting a lot of money into the mental health treatment, into a wig where we can actually reduce a lot of these issues and monetary expenses by allowing women the treatment that will preserve their natural hair.
Yeah, thank you. Thank you, Madam Chair.
You're welcome. So, just so that we know, I have Woods, Hill, Kipke, Vice Chair Collison, Morgan, and Warman next. All right, Delegate Woods.
Thank you, Madam Chair. I think you've answered a good part of my question. First, let me thank all of you for your testimony and for sharing this information. This is very new to me. So you answered part of the question with regard to the funding. My other question was, can you kind of explain the cold capping process? Because I don't know if I was hearing it correctly, but it sounds like it may not be the same for everybody, like the whole experience. Thank you.
Okay.
There are multiple types of cold capping. It's a great question. There are devices that, actually, Liz, you may be better to answer this, but.
I will.
Yeah.
There are basically two types of caps. All of them are FDA cleared, not FDA approved. There are manual caps, which require an additional person to help administer the caps on and off the patient's head. So if you are somebody who has the misfortune of not having friends or family who can take off work, you're probably not going to be able to do cold capping with the manual caps. Over the last 7 years, there's been a big effort among patient advocacy groups, as well as the few companies that produce these scalp cooling machines. These are machines that you can plug in at an infusion center. They are, quote, portable, though that is arguable because they are heavy and they're cumbersome. But those infusion centers that offer them, it makes the experience easier for patients because they don't have to have that helper, and it's the nurses that are administering them. And there are two companies, basically, although there's some additional players in the field that are coming up, but basically they're Paxman Scalp Cooling and Digniton or DignaCap. And again, those are FDA cleared. The efficacy is more or less the same. You could hear different anecdotal tales about whether the manual caps are more effective than the machine scalp cooling, but regardless, the technology is essentially the same. You are freezing your hair follicles to prevent the chemotherapy from accessing them and destroying the follicles. So those are the two main technologies.
Can I add something?
Actually, I'm going to allow it, but this is the only time we don't do it. The procedures for our committee, only one person can answer, okay? Because we have to be done today by 4 o'clock, and we still have how many more bill hearings left? We have 3 more after this one, but go ahead.
Well,
Go
I
ahead.
just want to make sure the question was answered in the way that you were looking for. So I don't know if this was part of the question about how it's done, but a lot of patients, they require to start the cold cap about an hour before the chemo, and for some chemos, up to 5 hours after the end of the chemo. So it's quite a long day beyond the couple of hours of chemo itself. And I'll also add, and this is relevant to your decision-making, is that not all chemotherapy regimens, even if they cause hair loss, are amenable to cold capping. So it's not for every scenario. There's a list of chemo agents or chemo protocols, which mostly for breast cancer, but other cancers that it's relevant for. And there are many other types of chemo protocols that it will completely fail to work. And there's actually guidelines recommending not to cold cap, even though hair loss is a side effect. So this would be limited to patients who have certain diagnoses getting certain chemo protocols, not all patients and all chemo.
Okay, you're welcome. Next, we have Delegate Hill.
Thank you. I don't know if this is for Delegate Goldstein or the woman on the end who has the not-for-profit that helps people. As I understand what you're saying, this is a device, so theoretically, it might be treated as a medical device under insurance instead of as a treatment. And it sounds like it's reusable. So there might be disposables with the cap, but the machine that has the cryogen in it can be used over and over. So theoretically, it could be, and this is the question, theoretically, could there not be purchased for the facility and a much lesser charge, since it doesn't seem to necessarily require staffing? But that's what I'm trying, what are the costs involved on a device? Is it the disposables? Is it the staffing? What goes into that? And maybe that's for you, Dr. Goldstein. I don't know.
Well, briefly, generally speaking, institutions do not purchase the machines. They contract with the company drops off the machine and it just sits there. And when it's being used, the patients generally, and the other patients here can comment on this, generally the patients pay to the company, not to the practice. Each session a la carte, and the practices are not involved in making any money off of it. It's just, the machines are just parked there for the patients to use per episode.
May I? No. Okay.
Delegate Kipke, and then Collison, then Morgan, then Werman.
Thank you. I know we're under a time crunch, so I'll just ask a quick question. Do you know if this is covered under Medicare or Medicaid?
So currently, it is not covered under Medicaid. It is partially, it's really tricky with the Medicare piece, and I hope I articulated correctly. I would rather someone else answer it. So it's my understanding that Medicare will cover it only if the devices are located at the doctor's office. So they would have to come in, pick up the device, and purchase it, or through that medical practice. So I'm sure that there's probably a clearer way to answer, but that's the gist of how it works. So yeah, somewhat covered by Medicare, just not enough.
Thank you.
Okay, next I have Vice Chair Collison, then Morgan.
Thank you, Madam Chair. Quick question. I've heard the number $2,500. Is that per treatment or for all of the treatments during infusions?
I know the doctor, I think, has the answer if you want him to answer, unless you know.
I was just going to say, I mean, that's typically for the whole course of treatment. So if you were a patient like, I think the two of us, where we had 4 rounds of Taxotere Cytoxin, for example, then it would be 4 times $200 or $250 or whatever the per infusion cost is for the given cold capping company. So if you get to 2,500, it's probably because you have had
8 rounds,
8 or 10 or 12, 16 rounds of Taxol or Red Devil. So when we were giving the range on the low end, it's probably right now, and the cost has gone down, 1,000, 1,200. The high end would be 3,000. So the average is somewhere around 2,200 or 2,500 total.
So, and just, it's only administered during, when you're going through the chemo itself?
Yep, the day of your infusions. It's the before they introduce the IV, during the IV, and then for an hour or 2 after the IV. So it essentially is your whole day.
Okay, great.
All right, thank you. I have Morgan.
Thank you, Madam Chair.
You're welcome.
Dr. Goldstein, good to see you again. Two-part question, really quick. You mentioned earlier that it wasn't for every patient that is receiving chemo. In your experience in your clinic, what is the percentage that would qualify for this? Mm-hmm. And then the second part of that question is, do people that use cold capping, do they experience a better outcome on hair regrowth after chemo is stopped?
So I would say generally true. If someone did cold capping, even if they lost some hair, yeah. There are some patients who, when they don't do cold capping, they end up with actually permanent hair loss. It can be 80%, 90%, or 100%, and it just never grows back. Now, as far as percentage-wise, that's going to depend on each practice. I know some practices that are breast cancer only practices. So 100%.
Well, I was talking to your experience. Just, I'm not going to hold you to a number, just ballpark.
Well,
what
in our
percentage
practice, excuse me, we have 3 full-time doctors, and we don't have a huge breast cancer population of patients, but on any given month, we might have between 2 and 5 patients who could be on cold capping, of which maybe only 1 is doing it. How about that? So, but it's not a high percentage in our practice. Okay. And there's other cancer diagnoses which are completely ignored because breast cancer gets most of the attention. But these regimens, these same chemo regimens, affect patients with ovarian cancer, lung cancer, and a few other things. And theoretically, you can apply this or offer it to those patients, both men and women. Right now, the vast majority of those patients are not being offered it at all.
Thank you so much. Appreciate it. Delia Warman. Okay.
Somebody else asked my question.
Thank you. All right. I have a couple of comments. The New York law goes into effect January 2026, correct?
I'm sorry, I didn't.
The New York law goes into effect
correct.
January 2026. It
Yes.
just passed this
December 24, that's correct.
All right. And we don't have any information besides what the doctor just said about how many people this will be in Maryland for certain.
Right. I mean, what I do know is that, and I pulled some numbers, so between 10 and 12,000 Maryland residents receive chemotherapy annually. But again, not all of them will qualify for cold capping, depends on the type of cancer. So that's the only number I have. And then I think there was another number, just about 35,000 new cancer cases annually here in Maryland. But again, that doesn't give you the specific
And do you have
number.
any numbers on New York?
I do not have them on me, but I can certainly get them for you.
Yeah, if you could contact Linda Rosenthal, who was the New York Assembly member, and get the file, her file from her, that would be great.
Okay, perfect.
Also, the Maryland Healthcare Commission, we need to make a request for them to look at it, okay? So that they can write a report as well. So we can talk offline about that.
Okay.
All right?
Great, thank you.
You're welcome. I want to thank all of you for coming, for being here. And if, I don't know what will happen with the bill, usually, it goes to subcommittee, depending on the fiscal note. Given that this is a mandate, right, and it will affect the premiums, we usually have to send it to the Maryland Healthcare Commission, all right? But it's pretty compelling, and we certainly understand the need for it, okay? I think I can speak on behalf of the whole committee as well. Thank you for being here. We really value your time. We do have more witnesses on this bill, so I'm going to go ahead and call them. Thank you, Delegate, for your leadership. We have next Rosalind Abbott-Riper, Christine Andriani, Lauren Michalski, Melissa Borstam, and we have Kashina Cross. Will you be so kind, all of you, and come up and just pull some chairs? And as soon as you sit, if you could get started with your testimony, that would be great. You can get started. They'll join you.
Good afternoon. I would like to thank Delegate Congolo for sponsoring this bill. My name is Rosalind Abbott-Ripper. I'm an Annapolis resident, a mother, a business executive, and a current chemo patient, having been recently diagnosed with breast cancer. Receiving a breast cancer diagnosis is a life-altering event. No one can ever be prepared to hear such news. Once my double mastectomy was completed in January 2025 and the pathology was run on my breast tissue, an 8mm HER2-positive tumor was discovered. HER2-positive breast cancer is very aggressive and fast-growing. I was immediately recommended for chemotherapy. Upon discussions with my oncologist, I was told I needed 12 weeks of Paxatal chemo, followed by an entire year of Herceptin, a targeted therapy. The grief at the realization of hair loss set in. I had already been through so much, and knowing my long treatment journey ahead was discouraging. I came to learn about cold capping and how, for my chemo regimen, I may have a chance of saving my hair. I received more information from the Anne Arundel Medical Center where I'm receiving treatment. I learned that they use the Paxman system and that I would be a great candidate for cold capping. What I wasn't prepared for was the out-of-pocket expense. Cold capping is not covered by my insurance as it's deemed cosmetic. How can this be? Every woman going through breast cancer deserves the opportunity and dignity to keep her hair during chemo when possible. I am fortunate that I was able to pay the $2,400 to cold cap. There are many other women who cannot afford to do so and lose their hair. For them, it is utterly devastating. I see this every day in the breast cancer support groups I'm involved with. Cancer patients go through so much physically, mentally, including financially. Keeping your hair should not be a financial choice. It should be a standard and treated similarly to the entire chemotherapy process. I recognize that cold capping will not work for some chemo regimens, but for those it has a greater chance of success, it should be offered as a choice. My thoughts are with all Marylanders who are undergoing or are currently experiencing a cancer diagnosis. Thank you.
Here and sharing your story with us as well. Next, please.
Good afternoon. My name is Christine Andriani, and I'm here to speak in favor of HB 1187. In September, I was diagnosed with triple-negative breast cancer. When I realized that my course of treatment would involve 6 months of chemotherapy, I began discussing the use of cold capping. After looking at the monthly cost and the duration of my treatment, I determined that as a teacher, cold capping would not be financially feasible for my family. Cancer takes so much from you, your health, your vitality, and in the case of breast cancer, part of your femininity. While you can't tell by looking, my long strawberry blonde hair has always been one of my defining features. Losing my hair has felt like losing part of myself. There are days where I look in the mirror and I don't recognize who's looking back at me. Having affordable access to cold capping would have helped make this very difficult process of cancer treatment a little easier, not only for myself, but for my 2 young daughters. My hope is that in the future, Maryland cancer patients will have cold capping therapy covered through insurance as part of their standard care. On behalf of all current and future Maryland cancer thrivers and survivors, I hope that you consider giving your support to HB 1187. Thank you.
Thank you, and thank you for being here, sharing your story. Thank you for teaching as well. We really appreciate you. Next, please.
My name is Lauren Maholsky. I'm the Executive Director of the Maryland, D.C. Society of Clinical Oncology as of January 1 this year. Medesco has submitted written testimony. I'm here to testify for myself and for everybody else.
Okay.
I'll get there. And I went short because I wanted to keep it light. My cancer diagnosis was in January of 21 during COVID. My surgery was in February, and I received chemo that spring and immunotherapy for the year. I was offered cold cap therapy, but unfortunately it was an added cost and added time in the chair. Not yet knowing the final tally of the expenses I would yet incur, I chose not to have the cold cap and did a crew cut instead. Nonetheless, it was brutal to watch it fall out, period. As you get used to the new look of your body post-surgery, hair matters, emotionally, physically, and spiritually. I'm seeking this committee to help cancer patients keep their hair in their own control and not that of the insurance underwriters and actuaries. Give each cancer patient the choice and the peace of mind as they go through their own journeys. Thanks for your time, and stay well.
Thank you for sharing the story, and I'm so glad that you're here, okay? It really makes a difference. No worries. Who's next?
Oh, great. Hi, good afternoon. My name's Melissa Borstam. I'm the Chief Communications Officer for Dignitana, which is the manufacturer of DigniCap, one of the 3 FDA-cleared devices. So I'm here today in support of HB 1187. You've already heard about the quality of life impact and the clinical importance of this, and of course demonstrated financial need. I hope that I can focus or answer some questions for you also on industry acceptance, availability, cost, and insurance. So to start with industry acceptance, in 2022, the American Medical Association issued a resolution in support of universal insurance coverage for scalp cooling. The American Society of Clinical Oncology has fully supported scalp cooling and initiated recent code changes which go into effect in January of 2026. And then the American Cancer Society also recommends scalp cooling for some patients as indicated in the clinical directions, and they recommend that on their website. I wanted to be sure to point that out because it is stated in the letter of opposition that the American Cancer Society does not recommend scalp cooling. Which is not true. They call me all the time. So in Maryland, there are 23 cancer centers in Maryland that offer FDA-cleared scalp cooling devices, and that includes both of the NCI-designated comprehensive cancer centers, Johns Hopkins and UMD. Of these 23, only 6 are currently filing for reimbursement. The others are all cash pay. Nationally, we have over 800 locations that offer scalp cooling with the devices, including every single NCI-designated cancer center, and most recently, 43 VA hospitals. So why are only 6 places in Maryland offering reimbursement? That is all about the uncertainty that you've been hearing about so far. So the cost of scalp cooling, I concur with what everyone else has said, on average is $2,500. In contrast, chemotherapy itself costs about $10,000 per infusion. So we're talking about less than 2% of overall treatment cost for them to cover this. And the device is leased. Our device, the FDA-cleared devices are leased to a cancer center, and then there's a per-treatment cost each time they come and have that infusion. So that covers the supply cost and the service for the nurses to administer the care. In terms of insurance, coding coverage, payment, so far progress that's been made. We currently have 2 Category 3 CPT codes that were introduced in 2021. Usage of those codes is low because coverage is not standardized. And then additionally, the coverage that we do have is low payment compared to what the charges are. And that result, as I said, is uncertainty. So 12% of providers are filing claims nationally, and 88% are only cash pay. We do have right now ongoing discussions with CMS regarding new Category 1 CPT codes that start in January of 2026. This payment will be based on the Medicare physician fee schedule from OPPS rate assignment. There'll also be a relative value unit assigned to provide guidance for private payers as well. And this will result in fair and reasonable reimbursement for the work done by clinicians, including practice expense. But what's needed is coverage policies to ensure standardization. In closing, to an insurer, $2,500 is, less than 2% of their overall cost, but to a patient, that's significant money that they need for housing, groceries, gas, and childcare. They shouldn't have to make that choice. The name of our company, Dignitana, and our device, DigniCap, stems from the Latin word dignitas, which means dignity. And that's precisely what this offers to cancer patients. So thank you for allowing me to speak today, and I'm happy to answer questions.
Thank you.
Thank you so much, and good afternoon. I am Mayor Kashina A. Cross from the City of Glen Arden. To Madam Chair, the esteemed delegates in this space, the advocates that are here to fight this race, we are here because this is an opportunity for us to stand up and become the second state in our United States of America to support. I stand in favor of House Bill 1187 because it upholds Maryland's commitment, the commitment to preserving dignity, self-worth, and hope for our cancer patients who undergo chemotherapy, a personal issue to me as my mother survived 15 years before having to have the breast removal surgery. Each year, nearly 35,000 Marylanders are diagnosed with cancer, and for many of those, chemotherapy becomes their best survival method. Now, that survival method saves lives, but it strips away what you have heard many times here, the deeply personal patient ideologies and identity. Hair loss is not just about the physical side, because a lot of people want to put a public marker on your illness, but that is about the self-esteem, the mental health, and even professional stability, where many have lost their jobs. Cold cap therapy offers a proven solution to mitigate and introduce an opportunity for all to save their hair. And as you heard the doctor say, it is not about women, this is about humanity. As we look at these treatments, the financial burden that incurs on a person, an individual, you've heard from $1,500 to $2,500. But let's do the math. If we have to do 24 sessions, that's $36,000. And now allow me to provide you a range of what that looks like. For breast reconstruction surgery, which is covered by many insurance companies, that's $50,000. I'll let that set in for a minute. We can treat 24 times to one breast, which is covered. These policies recognize that we are trying to preserve dignity. It is vital for us to treat this disease, to keep the confidence in our communities, to continue the fight for survival. By passing House Bill, come on now.
You got it. You got it.
We all know somebody. We all know somebody. This is a no-brainer. We're going to get the data. We're going to get the facts. And we ran this real quick because we wanted to get through it. We respect your time. But House Bill 1187 is an opportunity for choice to be made, to serve, Thank you so much for that, and I ask for your careful consideration, the respect and the dignity and the esteemed worthiness of this particular board as we give self-help and self-worth to those who have asked you to pass House Bill 1187. Thank you.
Thank you for being with us today, and I'm sorry about your mother. We really appreciate your testimony, okay? We're going to open it up for questions now from the committee. Are there any questions from the committee? We don't have any questions. It doesn't mean we don't care, okay? It's just that you are very impactful, all right? Thank you so much for being with us. Have a blessed day, and may you continue to heal. This actually concludes, before I conclude the testimony, Delegate Congola. Delegate? Delegate Congola.
I was caught up in the moment.
It's okay. There was a witness that testified that there are 23 centers in Maryland that treat for cancer. I want you to contact each and every one of those centers and get it in writing how many patients they see approximately every year. Yes.
Okay.
Okay? Who they think will benefit from this, okay?
All right, will do. All right, thank you all so much.
All right, thank you so much. And if you can get that to us in the next few days.
We'll be working on it right now.
This actually concludes the bill hearing on House Bill 1187. Next, we're going to House Bill 1314, Delegate Miller, Healthcare Prior Authorization Prohibiting Fees and Use of Artificial Intelligence. Will you be so kind and come up? Actually, you don't have a panel, just yourself, which is enough. How are you? You can get started.
I have to remember these every time I come here. It is astounding the work you all do, and it is much appreciated. You guys, one of the hardest working committees, and it just reinforces that what we do here matters every single day, and we make differences. Is it okay if I pass these out real quick? I forgot.
Yeah. Yes.
That way I don't have to read to you. And these actually are the most current from AMA about prior authorization and AI, which you guys are doing also an amazing job with.
Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the esteemed Health and Government Operations Committee. My name is Delegate April Miller, and I am here today to present House Bill 1314, which would prohibit healthcare providers from charging fees for prior authorizations and prohibit the use of AI to make an automatic denial of a prior authorization. This committee has done and continues to do a lot of really important work around the topic of prior authorization reform. I passed out the handout of the recent AMA paper. Please take a few minutes to look it over as they're talking about this very topic. I'm just going to read one quick quote. Notably, the AMA's augmented intelligence research released earlier this month found that nearly half of all physicians ranked oversight of payers' use of AI and medical necessity determinations among the top 3 priorities for regulatory action. Moreover, recently passed was an AMA policy that identifies significant concerns with insurer use of AI. The prospect of AI in automating prior authorization denials in health insurance raises serious ethical and practical concerns. While proponents may tout efficiency and cost effectiveness, the potential for algorithmic bias, lack of transparency, and the erosion of human judgment poses a significant threat to patient well-being. One of the most pressing issues is the inherent potential for algorithmic bias. AI systems are trained on vast data sets, and if these data sets reflect existing societal biases, the AI will perpetuate and even amplify them. For example, if historical claims data disproportionately denies certain treatments to minority groups, the AI will likely replicate this pattern, leading to discriminatory outcomes. This can exacerbate existing health disparities, creating a system where access to care is not determined by medical necessity, but by biased algorithms. systems. Furthermore, the nature of many AI systems make it difficult to understand the rationale behind a denial. Unlike a human reviewer who can provide a detailed explanation, an AI algorithm may simply produce a denied result without revealing the specific factors that led to that decision. This lack of transparency undermines patient trust and prevents them from effectively appealing denials. Patients and their physicians deserve to understand why a treatment was deemed unnecessary, and AI in its current state often fails to provide the crucial information. And moreover, relying solely on AI to automate prior authorizations risks diminishing the essential role of human judgment. Medical decisions are complex and nuanced, requiring a thorough understanding of individual patient circumstances. AI, while capable of processing vast amounts of data, lacks the ability to consider the full context of a patient's medical history, social determinants of health, and unique needs. A human reviewer, on the other hand, can exercise clinical judgment, consider extenuating circumstances, and advocate for patients when necessary. Replacing this human element with an automated decision-making could lead to rigid and inflexible denials, potentially denying patients access to life-saving treatments. The implications for the patient-physician relationship is also significant, and a system that prioritizes algorithmic efficiency over patient needs can erode the trust that is between doctors and their patients. Physicians may find themselves spending more and more time navigating complex appeals processes rather than focusing on patient care. This can lead to physician burnout and ultimately compromise the quality of the healthcare delivery. And finally, the potential for errors and unintended consequences is substantial. AI systems are not infallible, and even minor flaws in the algorithmic or data can lead to widespread errors. A single flawed algorithm can deny necessary treatments to thousands of patients with potentially devastating consequences, and the lack of robust oversight and accountability mechanisms further compounds this risk. So I want to tell you a little bit about the other part of this bill. I was here before you last week talking about situations around weight loss medications and automatic denials. So when I was going through all of that last year and trying to get different medications covered or different prescriptions and see what was going on, I called into my doctor's office about the issues that I was having with the prescriptions, and I told them that I might need to get another one, and they told me that they would now be charging for prior authorizations. Yeah, I couldn't believe it. And at the time, I think it was $35. And I recently called back to check again, and I think they now told me it was $15. I was shocked, and I figured out, okay, maybe it's just because of the type and number of that type of medication that was coming in. So I asked if this was for all medications or for just this type medication, and she said it was for all. So that created a lot of questions in my mind about what we were doing. I understand that we need to find a balance between managing costs and ensuring patient access to care is essential. So in essence, while doctors may feel justified in charging for the administrative work involved in prior authorizations, and it can be crushing and substantial what you have to go through, it raises ethical and practical concerns that could negatively impact patient access to care and further complicate the healthcare system. They can create financial barriers to necessary treatments. Charging for prior authorizations could disproportionately affect low-income patients, potentially limiting their access to necessary medical care. And it raises concerns about whether patients are being charged for a process that is essentially, it's a requirement imposed by insurance companies. And that also could put a strain on the physician-patient relationships, as patients may feel their doctors are prioritizing financial gain over their well-being. So I want to add, I did then speak to someone in the hospital industry, and I was telling them about the situation. And they were just saying,
I'm going to need you to start wrapping it up.
Yep, I'm done.
Okay, thank you so much. I appreciate it. We have a hard stop in
I know. You're
in
good.
an hour.
Thank you.
So I'm going to open it up for questions from the committee. Are there any questions from the committee? Vice Chair Collison.
So Delegate, we passed a bill today on the floor on third reader. Did that bill not meet? I mean, I understand that your second part of the bill is about a fee that this is the first I've heard of a provider requiring a fee for prior authorization. But did the AI bill that we passed this morning, did that not meet your concerns?
Yes, and hopefully that will continue, as far as through the process and everything. Yeah, I know we've had multiple bills about AI, which is, I was trying to go really quick through that part. But no, so the more concerning is the second piece, and happy to amend the bill if, however the committee chooses, if there is to, address that part, because I had never heard of it either. And it really shocked me when I made that call. And then when I was, like I said, I was bringing it up to someone that is in hospital, and their eyes were like, oh, that's a good idea. And I don't want that to be perpetuated, or as doctors, they have to hire people to deal with all these prior authorizations. I don't need to tell you guys, all the stories. So I understand that the desire to kind of pass that cost on, but it's not through any cost, part of the patient's error. It's not any fault of them, and it's a part of the process that they're victim to as well. So I don't want them further victimized by this. So happy to keep that part wherever it comes in, or if it gets possibly amended onto another bill. So I really appreciate you guys taking a look at it.
Thank you. Thank you.
And we will look at it. I know we have been doing a lot on AI.
You have.
Actually, we have, last year we passed a huge bill putting guardrails around it.
You guys have been doing an amazing
job. We
job.
dealt with it as well.
Yep.
Delegate Hill, her bill as well.
Yep.
So we'll have the if I can ask Delegate Hill and Delegate Vice Chair Collison to look at it and see what, if anything, we should be doing regarding your bill, okay?
Awesome. Thank you so much.
You're welcome. And thank you for being flexible with us today,
Of course.
We really appreciate you. Usually we're very generous with the time, but
It's not an issue. Thank you, guys.
thank you. So we do have now, I have an unfavorable. Matt Chantilano, would you like to give your testimony?
Madam Chair, members of the committee, Matt Chantilano here today on behalf of the League of Life and Health Insurers in opposition to House Bill 1314. We're opposed to this bill because we think it's in direct conflict or duplicative on House Bill 820, Delegate Hill's bill, which I believe passed third reader on the floor today. The League is also supportive of the AI approaches that we've seen this session because it provides further guidelines to ensure what is happening now. And it continues to not happen, which includes that no carrier ever makes an adverse decision with an artificial intelligence system. Contrary to a lot of misinformation we've heard over the past couple of months, all denials are part of the system are always made by a human. Repeat, all adverse decisions are made by a human. Before House Bill 820, the carriers also were operating under a bulletin that was issued by the Maryland Insurance Administration in April of 2025 that was directly from the National Association of Insurance Commissioners, a national bulletin which dictated the use and regulatory structure of artificial intelligence. All carriers continue to operate under that bulletin, in addition to the House Bill 20, which I am sure will become law very, very soon. As to the other portion of the bill that focuses on providers being prohibited from charging patients a fee for obtaining a prior auth form, lead carriers are supportive of this portion of the bill. No provider should be establishing a new revenue stream on top of their already existing contractual relationship with the carrier. They're already paid for administrative back and forth with the carrier. We were surprised to see this portion of the bill, and it was helpful to hear the delegate's explanation. It's not a complaint that we encounter often, but I hope we could nip this type of opportunism in the bud before it actually spreads to other parts of the market. So thank you for the opportunity. We urge an unfavorable report, but request the prohibition of the prior auth form fee to be considered in some capacity. Thank you.
I have one question for you. How do you propose we stop it?
I think you could prohibit the charging of any sort of form like we do, and you could do on a facility fee, an administrative fee. We could probably stop that with an amendment to this bill or to other healthcare bills that are still in your possession.
Okay. I would like you to work with Lisa on that, please.
Sure.
Thank you. Yes, because if it's happening, it shouldn't be happening.
I have not heard of it before until I saw it came in. It was
yeah.
helpful to hear the delegate explain it, but it's not provision that we've encountered much, but I think it would be important for this committee to address.
Well, I'm not surprised. People are always looking for opportunities to make a buck, right?
Madam Chair, last year I went to the pediatrician and they tried to include another fee and in a regulated space, and let's just say they picked the wrong person that day, and they did not get the fee from Mr. Celentano.
Delegate Alston.
Thank you, Mr. Celentano. I'm just curious, you said the decisions are always made by a human.
Correct.
Are those humans using computers in order to guide their decision-making process, like risk assessment tools to say that their medical knowledge is greater than that of the doctor who's recommended the medication?
Well, Delegate Alston, that's a great question. Obviously, there's automation that happens in everything healthcare, but the doctors that make the decision on your care have to be in the exact same specialty as the doctor that recommended it. It's a Maryland law.
Okay, but they're not actually seeing the patient. They're just
That's
looking
correct.
at the
They're
data.
medical directors on behalf of the carrier.
And are they using computer-generated systems to help guide their decision in terms of the risk assessment and whether or not to give the patient the medication or withhold the medication from the patient when they're going through these prior authorization processes?
I'm not sure I can define automated generated system at the table. I'd have to look further into that, but no computer is denying your care.
Thank you.
Okay, thank you. I don't see any other questions. Thank you so much for being here with us.
Thank you, Madam Chair.
All right, you're welcome. I believe that's it, yeah, for that one. So this concludes this bill hearing. If we can now, hold on a second. This concludes the bill hearing on House Bill 1314. We're going to go to Delegate Wims, House Bill 1291, Health Facilities Assisted Living Program Family Councils. And Delegate Wims, I believe you have George Carroll, Tammy Bresnahan, and Darlene Waleski on your panel. If they can all come up with you. And welcome to the Health and Government Operations Committee, Delegate Wims. How are you?
Doing well. Doing well. Thank you, Madam Chair.
You're welcome.
And I have good news for the committee. My testimony is only going to take 3 minutes.
Okay.
We have the others. Yes. First of all, good afternoon. Thank you, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. For the record, I am Greg Wims, representing House Bill 1291, Health Facilities, Assisted Living Programs, Family Councils. This bill would codify regulations assisting assisted livings for 15 beds or more. Family councils are important to keep assisted living facilities accountable. They provide a platform for family members to advocate for their loved ones and their needs. Current Maryland code regulates assisted living facilities, and family councils needed to be addressed. In reference to the Maryland Department's Health of Information letter that you received, it is a good letter, but it doesn't go far enough. These efforts fall short in creating robust regulations for large facilities that must follow. What does the bill actually do? Allowing facilities to create and lead a family council for no more than 6 months, at which point family council shall be led by a member of the family council. It requires the facilities to keep a public correspondence file that documents all dialogue with the family council. This file would need to be accessible upon request by the public during normal business hours. It also requires facilities to provide each new prospective resident with contact information for the current member of the family council, a description of the purpose and function of the family council, instructions on how to review the public correspondence file, and contact information for the local ombudsman. It would also set a 14-day time requirement for facilities to respond to any correspondence from the family council. The proposed COMAR regulations do not include any of the provisions listed above. Again, this bill would only apply to assisted living facilities with 15 beds or more. This impacts about 22% of all facilities in the state. This bill does not require assisted living facilities to have a family council. It simply outlines regulations on how assisted living facilities need to work with family councils to achieve outcomes that are beneficial to the residents and their families. With that, I ask for a favorable report. and then we can
For
start.
your
Yeah.
testimony, appreciate it. Who would you like to go next?
I'd like to
Delegate?
start from my left, and then.
Okay.
Good afternoon, folks, Chairman, Vice Chair. My name is George Carroll, and I'm here to testify favorably for this bill. My mother was in assisted living for over 3 years, and my written testimony, which I assume I've all received, describes the way family councils helped my mother and the other residents in her facility. So I won't be talking about that so much. Family councils improve the quality of life for the residents, solve problems without bothering the ombudsman, and reduce the potential litigation costs for the facility. My oral testimony today addresses the deficiencies in the recently revised regulations. Number one, the time to respond of 14 days is identical to the current regulations for family councils in nursing homes. My personal experience is that the written response to family council suggestions or grievances was no different at 14 days than at 30 days. Number two, recently updated regulations have no notification requirements for the facility to tell current or prospective residents of the possibility of a family council. Number three, the written correspondence between the assisted living facility and the family council is not available for view by prospective residents or their families as required in this current proposed bill, 1291. This would educate and inform prospective residents of problem-solving record of the facility regarding family council grievances. Number four, this process to revise the regulation has taken almost 10 years. When it started, I didn't have any gray hair. It's important to get it right. This bill will help improve the new regulations. And lastly, number five, the Department of Aging has consulted with a well-known lobbying group that represents the AL industry to put finishing touches on the revised regulations. The lobbying group is not primarily focused on the residents' needs. The legislature must give voice to the vulnerable residents in these facilities, and I thank you for your time.
Thank you for being here. We really appreciate it. Who is next?
Madam Chair, my name is Darlene Gillespie. I'm also from the Elder Care Advocacy Group of Central Maryland. Thank you for hearing my support of this bill today. I'm speaking also in memory of my mother-in-law, Henny Madsen, who was in assisted living for 7 years. Family Council resolves a lot of issues related to the residents' daily care in a less stressful and costly way without having to involve ombudsmen who are very busy dealing with major issues in assisted living. It is a great venue for keeping family members informed and updated regarding care issues. 14 days is more than sufficient for administration to acknowledge the concerns from the council. The current regulations allow 30 days. We are not asking for a solution to the problem in those 14 days, just acknowledgement that we have sent in something. The bill holds the council and administration accountable by asking that all correspondence be made available to prospective and current residents and family members. This shows positive communication and support. Yes, the current COMAR regs does address family council and makes recommendations on who can be present, declares the right of privacy, and allows a 30-day response time. What it doesn't embrace is logistics, the purpose, and making all correspondence available as a public file. This legislation will only enhance the current COMAR regulation, which has taken over 10 years to revise. Taking a little longer to incorporate this bill into the regulation is worth it. I ask you to vote for this House Bill 1221. Thank you.
And thank you for being here and taking your time, both of you. Hi, Tammy, how are you?
Good. Good afternoon, Madam Chair and members of the Health and Government Operations Committee. My name is Tammy Bresnahan, and I'm the Senior Director of Advocacy for AARP Maryland. On behalf of AARP and our more than 850,000 members across the state, we strongly support House Bill 1291 and thank Delegate Wims for bringing this bill to the committee. Why is the bill important? Empowers families and residents. Family councils provide a structured way for families to advocate for their loved ones and collaborate on solutions to improve care. It increases transparency and accountability. It opens the dialogue between families and facility administrators, leads to better oversight and higher quality of care. And finally, enhances residents' well-being. Family engagement has been shown to improve residents' quality of life, emotional well-being, and overall care experiences. I just want to give a shout out to Mr. Carroll. He has been forming an advocacy group for the last, I would say, 5 years. Once a month on Tuesdays, they get together and they talk about the issues in long-term care. And nobody pays him, he's just a concerned advocate and citizen who has had real life experiences in assisted living. And so I just want to give you a shout out that he's just not here today, but he's been engaged in this issue for years. With that, I'd like to ask the committee respectfully to give a favorable report on House Bill 1291. Thank you.
Open it up for questions now from the committee. Are there any questions for this panel? No. Delegate, did you meet at all with Ms. Kaufman?
I'm sorry, I couldn't hear you.
Ms. Kaufman, Donna Kaufman from Lifespan?
Yes, we have talked, yes.
Okay, because you're not going to get an opportunity to come back, and I know she signed up unfavorable. Before I call her, I wanted to give you an opportunity to tell us how are those conversations?
Thank you. First, I want to thank you for coming to my office and talking with me. The reason why I brought the bill forward and with my panel is what we found is she's saying they've been working on it for many years. And what I think from my life experience is that if we can get a bill passed, this regulation that we're looking for will take place sooner than later. So I'm bringing the bill forward so that we can have this bill passed this year. So that's what I would say with her.
But how are the conversations with them? Are they, because she's testifying unfavorable?
Yes. Do you have the answer for that?
I think Dana, she's more concerned about the regulations being held up. And I think what the delegate is saying is that we feel like that this will supersede the regulations. We also know that while some people think it's been 10 years, it's been more like 17 since new regulations have been. I think she also wanted to give you information versus you know how you have a block on if you do information, you can't submit testimony. She'll tell you that. I don't think she's absolutely unfavorable, but I think she wants to discuss her amendments.
Well, she signed up unfavorable, but we're about to find out.
Okay.
Yes. Madam Chair, would be remiss before I leave if I didn't say today I have shadowing me the Omega Psi Phi Fraternity Incorporated, the men you see in the purple, and they are supporting the bill also. Thank you, Madam Chair.
You should have said that to begin with. Thank you, Delegate. We really appreciate you. Let's call Ms. Kaufman. Will you please come up?
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. For the record, I'm Dana Kaufman on behalf of Lifespan Network, and we are opposed to the bill. We are not opposed to family councils, and I was relieved to hear that the witnesses before us had a very positive experience, it sounded like, with their family council in the facility where his mother was. Our issue then goes back to the fact that we have been working on these regs since 2016. When they were first proposed in 2016, 63 organizations submitted over 600 comments. I've been here since 2016 working on this issue, and I actually went back through all of the comments because there was a very good chart that OHCQ did, and the issue on family councils came up on 2 comments. One was by MACRA to thank them for the changes made, and the other one was to question, I think the issue ended up being that the section on family councils had gotten moved, of why something was stricken out. But those regulations have been vetted. The comment period ended on February 24th. It's my understanding that those regs are set to go final in publication in April, which means they will come into effect 10 days later. So the regulations will actually go into effect before any bill could go into effect. And we support those regulations. Our comment was, let these go. Like they're not perfect, but they're good. And we need to let them go. They did expound much more on the family councils and put additional protections. These go to all family councils, not just over 15, and we do think that's important too. But we really just want to be consistent. We want to adhere to the process that has been taken place and not have any consistency. And if there becomes an issues with family council, we can come back next year. But we do feel strongly that there was a very, very thorough process, and let's stick with it.
Are there any questions? Vice Chair Collison.
Oh, thank you, Madam Chair. So where are we with the regulations now?
So the regulations were proposed in the spring or fall, then they were reprinted just on January 23rd. The comment period ended February 24th, and I have heard that they are hoping, and they've slotted the regs to go for final publication in April, which will then regs go into effect 10 days afterwards.
So they're ready to go. It's just a matter of publishing them.
They're ready to go. Publishing them final.
Yes, that's what.
Yeah, and it's my understanding too. Just like Lifespan has been one of the more vocal, of course, organizations on these regs, and I mean, our letter was basically, let these go. Like, it is time. It has been 9 years in the making. And as you heard, that's 17 years before these regs had been changed. So that's our main concern. Like, we think that these were a really good compromise. They always say that if everybody's happy or if somebody's really happy, then it's probably not good. But, we all have our issues with the regs. So we ask that we just stick with the regs at this point.
Okay. Thank you very much. Thank you, Madam Chair.
Any other questions? Can you contact the department and get us something in writing that says when the day more or less they expect it to be done?
Sure.
Thank you. Not that I don't trust your word.
I have no problem with you not trusting me or asking, because again, these have taken 9 years, so we thought that they were going to have gone a couple years ago. So
I really would appreciate that. Okay.
Okay.
All right. I don't see any other. Okay. Any other questions? Thank you so much. I have 2 virtual witnesses. Will you bring them up, please? Morris Klein and Linda Berwoski. Are they there? Okay. Good afternoon. Will you be so kind, Mr. Morris Klein, and get started, please? Sir, can you hear me? Can you get started with your testimony?
Okay. Hello, good afternoon, members of the committee. My name is Morris Klein, and I'm here today on behalf of the Maryland, D.C. chapter of the National Academy of Elder Law Attorneys. Our organization serves seniors who need legal advice, including issues related to assisted living and nursing homes. The chapter is pleased to support this important legislation, and we think that it is very useful to have a family council. It's a critical step towards enhancing the quality of care and community engagement within assisted living facilities that will benefit residents and their loved ones, particularly with the rapidly changing ownership of a number of these long-term care facilities. It's important to maintain stability through a family council. There are 2 amendments that we are proposing to strengthen this legislation, which we otherwise support. We urge the committee to expand its reach to include all assisted living facilities, regardless of size, not just those above 15. In addition, we would seek to have the Maryland Long-Term Care Ombudsman authorized to create a family council, which would help ensure the establishment of this vital organization if the facility is not able or willing to see to its creation. that in a nutshell is my testimony, and I'm happy to answer any questions. Thank you for your consideration.
Thank you for being here. We appreciate it. Next, please. Ms. Linda.
Good afternoon, Madam Chair, Madam Vice Chair.
Good afternoon.
Thank you for the opportunity to testify on HB 1291, and thanks to Delegate Williams for sponsoring the bill. My name is Linda Brogowski. I'm the co-chair of the Montgomery County Commission on Aging, and assisted living is a crucial part of our constituency, 100,000 older residents. We support the intent of the proposed legislation and offer 4 friendly amendments. As Mr. Klein mentioned, we suggest that the legislative language in the bill reflect the current regulatory definition, licensed assisted living, and therefore should apply to all assisted living programs, regardless of size. We also agree that the long-term care ombudsman should be involved in the creation of a family council. We also suggest residents and family members should be invited. Once the council has been created, it's not 6 months, but as soon as the family council has been created, we think that the direction of the family council should be turned over to the families, the family representatives, and the long-term care ombudsman. They can be involved. The family can ask for the operator to be involved if that's necessary. We suggest amending Section E so that the facility response time of 14 days could be escalated if the communication states that a response is needed urgently or is time sensitive. And then finally, we would ask that Section C be amended so that other individuals can be designated for membership by the individual family council. In other words, they can select additional members to invite. Family councils and assisted living are not new to Montgomery County. We've had a local ordinance since 2002. We believe that as assisted living continues to grow and the demand for it grows, family councils become even that much more important. And so knowing how important family councils can be, we request a favorable report with the amendments. Thank you very much.
Thank you both for your advocacy. Are there any questions for these 2 witnesses? Seeing none, thank you so much for being with us today. We really appreciate it.
Thank
you. You're welcome. You're welcome. This actually concludes the bill hearing on House Bill 1291. Thank you, Delegate Wims. Really appreciate it. As soon as we get that letter, we will share it with you. Thank you. Next, we have our last bill. It is now 328. We have House Bill 1086, Delegate Martinez, Maryland Medical Assistance Program and Health Insurance Coverage for Anesthesia, prohibiting time limitations.
All right. Thank you so much, Madam Chair and esteemed members of the Health and Government Operations Committee. For the record, I am Delegate Ashanti Martinez, here to present House Bill 1086. This critical piece of legislation ensures that patients undergoing medical procedures are not unfairly burdened by arbitrary time restrictions on anesthesia coverage. At its core, this bill addresses a fundamental issue of fairness and patient protection. Recent reports have highlighted troubling attempts by insurance companies to impose time limits on anesthesia coverage, creating the possibility that patients may be forced to bear additional costs for a service that is entirely beyond their control. When a patient is under anesthesia, they have no agency over the duration of a procedure. The responsibility for a surgeon's length rests solely with the medical professionals performing it, and no patient should be penalized financially because a procedure takes longer than expected. More importantly, these restrictions create dangerous incentives that could compromise the quality of care. Surgeons should be focused on performing procedures with the precision and thoroughness required for the best possible patient outcomes, not constrained by artificial time limits imposed by insurers. HB 1086 ensures that patient safety remains the priority and that Marylanders can access the care they need without the fear of excessive and unjustified costs. I also want to note for the committee that there is a potential amendment being drafted just so that we can ensure the bill is really strong in language that insurance providers may not establish, implement, or enforce any policy, practice, or procedure that imposes a time limit for the payment of anesthesia services provided during a medical or surgical procedure, and may not establish, implement, or enforce any policy, practice, or procedure that restricts or excludes all anesthesia time for the payment of anesthesia services. This legislation has garnered strong support from key stakeholders who you'll hear from and you'll see in your floor systems. Their advocacy underscores the importance of ensuring that patients receive the full medical care they require without financial barriers imposed by insurance policies that prioritize cost cutting over patient well-being. For those reasons, I've respectfully urged the committee to issue a favorable report on House Bill 1086.
Next, please.
Madam Chair, members of the committee, my name is Dan Shattuck, here today on behalf of the Maryland Society of Anesthesiologists. I wear a couple hats. I'm their executive director. I want to thank the delegate Martinez for bringing this bill forward. It's very important, very timely. We've heard in the press the efforts by other carriers in the United States to try and put arbitrary time limits on anesthesia. And we have a panel of experts that can speak to the dangers that this presents. On the bill itself, the amendment that was described by the delegate is just an effort to further strengthen the language to make sure that we're not just looking at the time that anesthesia is administered when you're in the procedure room, but the care that's delivered pre-anesthetics maybe before they go into the operating room, and then the time until they're safely transferred to another provider after the anesthetic procedure is done. There are 6 other states currently that are pursuing this type of legislation. Spans the country: Connecticut, Illinois, Missouri, New Jersey, Oklahoma, Washington State. We applaud Maryland for considering this bill, and thank you for your strong support.
Committee, hello. How's everybody doing this afternoon? So I'm Dr. Michael Webb, and I am the president of the medical staff at Anne Arundel Medical Center. I'm also the medical director of anesthesia services for Luminous Health. And I'm also the vice president of a private anesthesia company called the Anesthesia Company, based here in Annapolis, Maryland. And I'm just here to say thank you. This bill is fantastic. When Anthem announced that they were going to put limitations on time, it shocked everybody. And you know, the public response was awesome. The social media response was awesome. There were these images of, you know, people in the middle of their operation having an egg timer go off and say, "Oh, anesthesia's done." But this is really much more serious than that. In first blush, it's an anesthesia payment. It's paying for the time that anesthesia is being performed. It's true that we are not in control of time in the operating room. In fact, it's very complex. It's surgeon skill and diligence, their meticulous execution of their job. It's Mother Nature. Sometimes we're just standing in the operating room looking at the human body, waiting to decide, is it going to bleed, is it not going to bleed? There's a whole bunch of things that can happen. And sometimes that takes time. And then there's equipment, technology. They fail. Sometimes we have to get new equipment. Then there's consultation. Sometimes you're in a situation where the answers aren't clear and you have to call other physicians to come in and consult with them. So time is very complex. And then, as we said, it's really not an anesthesia. It is an anesthesia issue, but it's much, much broader than that. It's a patient care and safety issue. If a surgeon is under undue stress because of time, mistakes are going to be made, quality issues are going to develop, malpractice cases are going to be generated. The other thing is access to care. Also, if there's limitation on the cost of anesthesia, this will impose increased cost burden on the hospitals, because when the egg timer goes off, we don't stop. We continue to care for the patient. Thank you.
Next, please.
Thank you, Madam Chair. Members of the committee, my name is Bill Kress. I'm here today on behalf of the Maryland Association of Nurse Anesthetists. There are 900 in Maryland in strong support of this legislation. Look, Dr. Webb explained the issue, and this should be a matter of providing the right clinical care based upon the patient who presents. This is a real issue in that 3 states experience a limitation of time from an insurance carrier. That lasted for about 3 or 4 months. The outcry was enormous. And in December of 24, they renounced that decision. We're concerned that it could occur with other carriers. We're concerned that it could occur in Maryland. So this legislation really is prophylactic, but we think it's important. I know it's late in session, and I know I'm your last witness of the day. So I will end it with that and ask for a favorable report. Thank you.
Thank you. We're going to open it up for questions now, unless we do have 2 virtual ones. Can you bring them up before I open it up for questions, please? I think it's, you see them? What was it? Oh, they're joining? Okay. Good afternoon. Will you be so kind and get started?
Sorry, Veneria. Dr.
Yes, hi, how are you, ma'am?
Sorry about that.
Will you please get started?
Yeah. Thank you, Madam Chairman. I'm Dr. Ram Paravemba. I'm the current president of the Maryland Society of Anesthesiologists. I'm here to speak about House Bill 1086 with amendments. I just want to reinforce the critical work that anesthesiologists provide, obviously intraoperatively within the operating room, but also the critical work that they do in the pre-op arena as well, in preparing patients for the operating room and developing plans to provide pain management through different modalities, which are critical, particularly these days when we're trying to decrease the utilization of opioids and so forth. So the anesthesia time certainly should not be limited in such a fashion as it reduces the capacity to serve the patient in the most critical ways. In addition, as I've spoken during other sessions or other times, we also have a critical shortage of anesthesia providers in Maryland. And I think it's critical that we are able to maintain private payer reimbursements at a time when we are relying significantly on hospital subsidies to allow us to recruit physicians within the state. So I just want to reinforce that it's critical that we are allowed to bill for adequate time or to manage patients both during operations and to serve those purposes that I mentioned earlier, both prior to operations, in preparation, and in providing pain management for patients and stabilizing patients when necessary in the post-operative period. So thank you very much.
Yes, I appreciate it. Rob Thompson?
Thank you, Madam Chair. I'm Rob Thompson. I'm an anesthesiologist. I'm the Vice Chair of Human Resources and Patient Experience at Johns Hopkins. I am also on the American Society of Anesthesiologists Administrative Council, and I'm a member of the MSA speaking on behalf of the Anesthesia Society. These kind of time limitations disproportionately affect academic medical centers. The 2 of the biggest healthcare providers in the state are the University of Maryland Medical System and Johns Hopkins Medicine. You can imagine that if you have arbitrary time pressure and you're trying to educate the future healthcare providers, both nurse anesthetists and physicians, you are going to have pressure to cut corners, and you're not going to train people to take care of our future patients properly. We have also heard that there has been interest in some of our providers or some of our payers limiting the time for payment of labor epidurals. You can never think that if you were in pain on the labor floor, expecting the joy of your first child to have an egg timer set for how much your pain is going to be controlled. So for these reasons, I strongly urge passage of this legislation.
Thank you. I'm going to open it up for questions now. I see Delegate Kaiser, followed by Delegate Kipke, followed by Olston, and then Bandari and Werman.
Madam Chair? Thank you, Madam Chair. Can I defer first to Delegate Kipke, who had his light on before me?
Oh, I didn't know who had it first. I just saw you two there, so.
All right.
Go ahead.
I tried.
Thank you for being nice.
Once a week. Madam Chair, thank you for the question, Madam Chair. To the delegate, thank you. This all really made sense to me. I was looking at the letter from the Office of the Attorney General, and see, I thought I had another minute to think while he was asking his question. But, one of the concerns they had, which they were saying, we worry that the mandated coverage of anesthesia services without any guidelines to manage the cost creates opportunities for fraud, waste, and abuse. I can't even imagine what fraud, waste, and abuse looks like in anesthesia. So I don't know who can address that comment in the Attorney General Office's letter. It seems far-fetched.
Medicare has very strong rules regarding anesthesia billing, which definitely minimizes any fraud and abuse. And fraud and abuse would take on the lighter side or on the sort of the mainstream side, the concern is, are you padding an extra minute on the front or the back of the care? And Medicare does have very clear guidelines on that, and those are also supported by Joint Commission, who routinely, comes in and goes through our charts and surveys hospitals regarding anesthesia care.
Thank you. That makes sense.
Thank you, Madam Chair. I've heard how this impacts an anesthesiologist or nurse anesthetist, and I've heard about the mom in delivery. How does this impact a surgeon?
So it's interesting you say that, because today I was in the operating room and I was working with the general surgeon, and I said, let's play a little game. Let's pretend that at this moment the insurance company has reached the time limit and we're no longer getting reimbursed on the anesthesia part of this procedure. Well, the surgeon right away said, well, that's instant anxiety, because they know that they can't operate without us. So we have to be viable. We have to have providers in the state of Maryland. We have to have viable companies to supply the anesthesiologists and nurse anesthetists. And so it forces people to human behavior. It encourages cutting corners, working at in duress. And with those things comes decreased quality and increased complications.
Thank you.
Delegate Alston.
Thank you, Madam Chair. I'm not sure who the best person is, but I'm just wondering, I've had several surgeries, so has my husband, and the time is never what they say. Sometimes it's faster, sometimes it's shorter. Sometimes it's really long, which is very scary, because every minute beyond what you've been told, you're worried that something's wrong. And I don't want to worry that they're running out of pain management or waking up in the middle of one of these processes. So my question is, can you even standardize the amount of time, and why would it be difficult to do that? Yeah.
So this is interesting, because when I first heard about Anthem's move to do this, it's not an anesthesia issue, it's an effort to control a surgeon. And it's wrong, because as I said before, all of the things that are happening in the operating room, the surgeon's only a part of it. Mother Nature is an enormous part of it. Technology is a part of it. Team function, the complexity of the anesthesia. There are things that we do that sometimes take some time. I just had a patient last week that we had to do invasive monitoring on, and all of that took place before the operation ever even started. That was almost an hour, which is routine in a cardiac surgery. So there is so many variables to executing an operation well, and to make sure that the patient is safe throughout and looking for the best possible outcome. It's impossible to really, and this drives schedulers crazy, but it is almost impossible to guess, other than a routine surgery, how long something is going to take.
Thank you, Madam Chair.
You're welcome.
Thank you, Madam Chair. The wonderful bill. This bill emphasized the coverage for the anesthesia must be provided for the entire duration of the procedure. Could the panel explain the complete range of patient care involved in administering anesthesia? And I would like to understand how this anesthesia time extend beyond just the operational procedure itself.
Yeah, it's the operation is the majority of the time. Again, Medicare specifies it has limits on the time before you go into the operating room, which starts with the administration of a sedative to help with anxiety, or the application of a nerve block to help with the pain after the operation. And then after the operation, there's a customary time that's expected regarding the handoff of care to the recovery room. Now, the anesthesiologist is in charge of the patient while they're in the recovery room for hours after the operation. We write orders on patients, we see patients, we examine them, we take care of medical issues. None of that is billed. That is all outside of anesthesia billing. So there's a lot of care that takes place even outside of the traditional billing system.
Thank you.
Thank you. So I'm not a doctor and I'm new to the committee, so bear with me. Can you just, in simple terms, tell us how does what happens to the patient when we're putting in these time limits, like to actual patient safety? What is it that we're talking about?
So the actual patient safety comes from this feeling that there's a limited time of anesthesia that you get, which could lead to rushing, and it's the operating room is a stressful place to begin with, and to say that you have to do all of this within a specific amount of time, you can imagine, right? In just about any task that you do, if someone puts time pressure on you. And sometimes Mother Nature puts pressure on us, and there's no getting around that. But I think the human factor of it is important because it will affect performance.
Thank you.
Thank you. Delegate Bandari.
Madam Chair, I just wanted, you had mentioned something in response to somebody else's question about all but routine surgeries, so I just wanted to share. So this is going to be an isn't that so question, just to let you know. Because a person close to me went in for a routine appendectomy. So I thought it was going to be in the ballpark of an hour, a little bit more maybe. Doctor came out about 45 minutes in and said, what we found isn't really routine appendectomy, and we need to take a good chunk of the colon also because they were concerned that it was colon cancer. So first of all, I was very grateful that he came out and talked to me. And I know that part of that was because I needed to have to say kind of like, yep, please go ahead. But he took time and walked me through and explained what was going on. And then it took probably, I don't know, it was, I'm going to say 2.5 to 3 hours. So again, very routine turned out to not so routine. And isn't that so that can happen? And this would be a problem because of that.
Yes, and that's, I wish I could say that was, an uncommon experience, but it's very common.
Sure.
To think that you're going in and you're going to find one thing, only to find out that it's much more extensive than expected.
Thank you.
And it doesn't have to necessarily be a new condition that's discovered. It can just be a more complicated situation with the condition that they thought they were going in with. Like taking out an appendix can take different lengths of time at times if it's more severe.
And it turned out it was only the appendix, just restart up.
Thank you. Veras.
Yes, I just want to thank you, Madam Chair. Sorry, I'm not feeling 100 here. But just to try to find out a little bit, the root of this is, I understand that as a result of some of the activities that happened this summer, is this the impetus of this bill? Given that there was the threat of insurance companies to try to charge, like in the middle of surgeries and such?
Yes, that's exactly right.
Okay.
I don't see any other questions, so I just want to thank everyone for being here today and for being patient. This actually concludes this bill hearing. And if you could just stay seated 1 second, and we're done with bill hearings. You could take us down, please.